Welcome to Transforming VTE Care, from risk identification to protocol implementation. This is the final episode in this Continuing Medical Education, or CME, series. Previous sessions covered the importance of VTE awareness, patient evaluation approaches, anticoagulation selection, the patient journey, and effective communication strategies in VTE management. Today, we're going to focus on developing and implementing quality improvement strategies in VTE care management. As we get started, I want to mention that this series is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance. Recommendations and opinions presented may not represent the official position of the American Heart Association, AHA. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA. The AHA does not endorse any product or device. I'm Dr. Erica Shore, Chair of the Adult and Gerontological Health Cooperative and Associate Professor in the School of Nursing at the University of Minnesota. And joining me today is a distinguished multidisciplinary panel.
Hi, I'm Dr. Snehal Bhatt, Professor of Pharmacy Practice at the Massachusetts College of Pharmacy and Health Sciences and Clinical Pharmacist at the Beth Israel Deaconess Medical Center. It is a privilege to be here.
Hi, my name is Dr. Jeffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan. Really excited to be here for this discussion.
Thank you both. As speakers for this series, share with us how healthcare professionals can leverage insights to advance protocol-based practice to improve clinical performance, personalize treatment decisions for complex patients, strengthen communication strategies across the care continuum, and identify and address common barriers in practice. So let's start with refining and standardizing protocol-driven approaches to improve clinical performance. When you think about the role of evidence-based guidelines and consistent implementation across care teams, what comes to mind?
Well, I'm happy to get started here, and Snehal, maybe you can jump in afterwards. In the world of VTE care, there's so much evidence that informs our guideline recommendations. I mean, I can think of things like VTE prevention. How do we assess who's at risk for VTE, either during a medical hospitalization or a surgical procedure? How should we think about giving them chemoprophylaxis or other forms of thromboprophylaxis? I can think about how we go through the diagnostic approach of determining who does or does not have a DVT or a PE. And then certainly something that, Snehal, you and I have talked a lot about in the past is how do we think about the best treatment strategies, right? Who should get oral therapies? Who should get parenteral therapies? What are the right doses? How long do you treat them for? There's a lot of evidence and a lot of guidelines that could be used to really think about ways to better standardize care and improve care delivery for patients.
Yeah, Jeff, absolutely. I think you hit the nail on the head. It's a great way to get started. The entire spectrum of this disease, really, it takes a village, right? I think the biggest things are using the guidelines, the available data. And Jeff, as you said, we have a lot of data. We still need a lot of data, right? But taking the best available data you have and really customizing or individualizing it to what works best within your institution to meet the needs of your patients, right? So we can certainly evaluate clinical trial data, but if you don't have the ability to implement that in a fashion that can reach a patient safely, it doesn't really matter if intervention X was better than an intervention Y. So I think taking the data, taking the resources you have, both from a health system standpoint, an EHR standpoint, and then who are the experts, who are the individuals who are really passionate about providing this type of care, and aligning all of those folks together to really to create what works best for an individual institution.
And not trying to do everything at once, right? But find one piece of the continuum of care and say, okay, we're going to focus on that. We're going to sort of get some engagement, get a win, and then use that to propel you to the next stage.
Rome wasn't built in a day, right? One piece at a time, get those small victories, right? Get that culture of we can actually do this, and then you can start to build from there.
And what role does interdisciplinary collaboration play in this?
I don't see, with all due respect to any individual profession, I don't see how you can do this without having every specialty in the room, I mean, every discipline in the room. We all see things from a slightly different focus as it relates to the patient. And really, right, the patient's in the middle. And as much as they can guide us with shared decision making, a lot of times for our patients, I think we fail to acknowledge how challenging the health system can be for them. It often probably feels like they're standing in the middle of a freeway with cars zipping by them at all sorts of speeds. But I think that, within our respective specialties, we have the ability to provide a different lens or a different framework that's important for the rest of the team to be able to acknowledge, right? So, Jeff, you mentioned the diagnostic piece. I am always fascinated by, is that an incidentaloma or is that real? And then, having our nursing colleagues being with us to say, well, is this really going to happen for this patient at this point in time? Our physical therapy colleagues can give us a lot of guidance on, how mobile, how frail is a patient. So there's so many specialties that need to be at the table. I just don't see how you could implement something safely and effectively without getting all those viewpoints. Jeff, what do you think?
I fully agree. And don't forget about your non-clinical colleagues too, right? Who knows how to pull data out of an EHR so that you know whether there is a care delivery gap or that you're actually closing it? Who knows how to design those things in your EHR system that may be great tools that you can use, right? Who are the quality improvement or performance improvement coaches that are going to sort of get your team going and making sure you're staying on track? So I fully agree. It's interdisciplinary, both across all the clinical areas, but also some of those non-clinical areas as well.
That's a great point, Jeff. Sometimes each of us in our clinical areas, we kind of have our blind spots or our biases, and having some of those folks who don't see it from a disease, but they see it purely from a data or an EHR perspective can really guide the end user interface things that we may not be thinking of in the same way. Having those people in the room, that is such a great point.
Yeah.
Let's move on to personalizing treatment decisions for patients that have complex needs. And let's start by talking about adjusting treatment plans, reassessment, and frequency. How is that handled?
Well, I can give you a great example. We have a PERT team that helps to care for our patients with PE. And this is exactly the kind of thing we do. I've been on call here over the last week, and we've had some really complex cases. And exactly the question you ask, I think, is the value that the team brings, right? Assess a patient when they first present. What's the best therapy? Are we going to choose anticoagulation, or are we going to choose some sort of invasive treatment, maybe a catheter-based therapy or something? We chose, and we usually choose to do anticoagulation first. How's the patient going to respond? What's the right drug? Are we using a unfractionated heparin, a low molecular weight heparin, or an oral agent, right? How do you personalize that? It's great when there's multiple people at the table who can help guide that decision. But I love that you asked the question about the follow-up or the monitoring. I'm thinking about a couple cases I've had recently where patients initially were doing fine. We put them on anticoagulation. Those first, 24 to 36 hours, they were doing okay. But then things started to not do as well, and they started to get a little worse. If we weren't there to monitor and to say, okay, is this patient continuing to improve or not, we wouldn't have known, we need to now step up our game, get more aggressive, intervene to make sure that we can best treat that patient. So this idea that you need to have a sort of robust assessment initially, but also as they follow along in the hospital and then eventually through that transition of care, I think is absolutely critical.
Yeah, I agree. Everyone's got a great game plan, but our patients have different stories to tell, right? And so having, just staying on top of this disease, it's a challenging and a very humbling disease. And the best laid plans can sometimes, through no one's fault, go awry. And having that framework in place of what good follow-up looks like, what does that mean for every individual member of the team? And then what do you have from your framework to quickly pivot when you need to? Like we often are, when we think about transitions of care, oftentimes we're thinking about de-escalation. But Jeff, I like your example because sometimes that does require escalation. And Erica, you mentioned drug therapy selection. So I'm listening to folks like Jeff, and I'm listening to our nursing colleagues, and I'm thinking, okay, we're on the fence about intervention versus no intervention. Picking the right anticoagulant in that patient is a little bit more challenging in terms of, unless you're in terms of a different patient where you say this patient does not seem to be a candidate for intervention at this time, right? So really thoughtful listening and knowing which agents allow you to pivot in one way or another in customizing that care in a multidisciplinary fashion is so important.
So, building on that concept of individualization, what patient specific factors are important to consider when we're thinking about personalized treatment for patients?
So from a pharmacy perspective, I'm thinking about, thrombosis versus bleeding and where are we in that spectrum? So again, I'm listening for everything that my other team members are talking about with regards to comorbidities, frailty, severity of disease. What does the imaging look like? I don't read images as a pharmacist, but I think it's important to really have a grasp of why is the rest of the team concerned about this particular image, or why are they comforted by this particular image? Those are things that I take into account. And then most of our medications have different levels of clearance and metabolism. So organ function is really important here. Hemodynamic stability, I think, plays a big role in terms of identifying which patient would be what is the safest but still most effective agent. Jeff, what are your perspectives when you think about this?
You hit so many important points. One that I'll add is looking at the other medications a patient takes. That's really critical. In the era before the direct oral anticoagulants came out, we just assumed everything interacted with warfarin, but we had the advantage of an INR. You could always check it and adjust the dose to figure out how to do it safely. These direct oral anticoagulants are so much more convenient because you pick a dose and you sort of use that long term. But we have to remember there are still important drug-drug interactions, right? Things that interact with the P glycoproteins or the CYP3A4 pathway. But there's also other agents that have associated bleeding risk. And as a cardiovascular specialist, I see a lot of people on aspirin who then get started on one of our DOACs for treatment of, let's say, a DVT. Well, we need to reassess, do they need the aspirin? Could they stop the aspirin as a way to minimize their bleeding risk? If they really do need aspirin, maybe they've got a condition for which aspirin is really critical. Are there other strategies we can use to lower their risk of bleeding? Maybe using a proton pump inhibitor or something like that. So there's also that element of personalization to just the other medical therapies that a patient's taking.
Jeff, you said that so beautifully, and that's been most of my week on service has been trying to teach some of our younger physicians the framework of aspirin anticoagulation. And aspirin often gets sort of viewed as almost like a bystander in someone's medication list. And I think that we've learned through a lot of really important data that maybe the framework needs to shift a little bit. And when you see an anticoagulant on board, the question may be, does this patient need aspirin, as opposed to, oh, well, we just have both on board, right? I think that we need to flip that framework a little bit because, as you mentioned, there may be some really important reasons to combine both of those therapies, but the default approach might be, aspirin, no. Can I find a reason for yes?
Yeah. And because it's a DVT or a PE, what was the setting in which that occurred? How does that impact the length of treatment we're thinking about from an anticoagulation standpoint? And then what does that mean for the antiplatelet? A great example is maybe somebody who was taking aspirin for, primary cardiovascular prevention, then has a knee surgery and a couple days or a week later develops a DVT. Well, we may choose to stop aspirin because it was a primary prevention thing while they're on their anticoagulant. But this was a clearly surgically provoked DVT, which means we probably are only going to give them a short duration of anticoagulation. Well, then what do we do with the aspirin at the end of it? Should they go back on? Should they not? What was the real reason for them taking it? So there's a lot of pieces there that also have to be managed. Again, that's why it's important to think about this at the time you're diagnosing them, at the time you're initiating anticoagulation treatment, but also following them all the way through the end of that therapy to see what other elements may need to shift around.
Yeah, many of these points that you each made about individualized treatment decisions really reinforces the value of interdisciplinary collaboration and the role everyone plays. When we start thinking about communication strategies, do you see areas in which that can be strengthened across the care continuum?
I mean, clearly the answer is yes. I think the biggest challenge is how do you do that? Communication is just so central, right? If we as clinicians are not communicating amongst each other in a really clear way, you tend to get things that are missed, right? If I'm not clearly communicating to my clinical pharmacist about what's the diagnosis, what are we thinking about from a treatment standpoint, it's hard for the clinical pharmacist to help me and help the patient say, well, here might be the best anticoagulant for this individual patient. But I also want to stress the importance of communicating to the patient and to the family, right? They want to understand why they're taking these medicines, how long they need to take them for, what potential side effects might they experience, and if they have questions or concerns, how do they get back in touch with you? So communication happens sort of in multiple levels or domains.
Yeah, think about this from you have your system level communication, which is like your protocols, guidelines, and pathways. And then you probably have your subcommittees and their communication as they refine those to really be something that's practical. And then in the realm of patient care, you have the team to team, discipline to discipline. And then Jeff, as you mentioned, everything then goes back to that patient, right? So it's really multi-layered, and every one of those requires some differences in terms of how you can be effective across your health system.
Yeah.
Great. What would you say could be learned when we think about identifying and addressing common barriers in practice that currently exist?
Right. Well, I definitely think that there is a lot that we could be learning from each other. I think one of the most powerful opportunities is when we as health system leaders in these areas go to other places and say, how are you tackling this, right? What have been your experiences? What solutions have you come up with? How could I learn from you to help take better care of my patients at home? And in my career, I've been running one of these multi-center collaboratives for over 15 years. And it's so incredibly powerful how people come together to share their best practices, their lessons learned, and really together we're improving care for everyone. So I really think that sharing and listening sort of outside the walls of your institution can be a very powerful and effective strategy.
Yeah, to piggyback off of that, Jeff, I think that, identifying who your local champions are and then empowering your local champions to really help drive change, because we have a lot of data, like you said, and yes, we certainly need more data, but there is still this force of clinical inertia that is always fighting us, right? And I think that it takes the village, but you have to identify who the champions are and really support those individuals to drive change.
Yeah, because it's just human nature. We always fall back on the things that we have a history of doing and are familiar. And to really change that behavior takes a lot of activation energy and takes the opportunity to test things out, see how it goes, and see whether or not that feels like it fits well, right? It's like when you get a new pair of shoes, you want to try them on and see whether they fit before you go running or go, to a big party. And I think the same is true as we're trying to improve care for our patients with VTE. Understand that this is not one or two clinicians you're trying to change. This is sort of everyone in different facets of the healthcare system. So you have to really help them and help get them activated and get them going. Give them opportunities to try things out in a safe way, know that they have the support of their colleagues around them, and then hopefully they have a good experience. So then that reinforces the need to keep making that change into the future.
Absolutely. Up to this point, we've discussed protocol-based practice improvements, some personalized treatment decisions, communication strategies, and also barriers in current practice. As I mentioned at the beginning, this is a CME series, so I'd like us to move on to discussing how knowledge from the series can support the development of performance and quality improvement, PI/QI interventions, specifically in VTE care. Let's start with clarifying the difference between PI/QI and traditional CME.
Well, I'm happy to give it a start. When I think about sort of performance improvement and quality improvement, it's really about understanding your own practice right? And when I say your own, it could be you as an individual. It could be maybe my team or my clinic or my hospital or my health system, right? And using some of that data to say, okay, how can we get better? What does the evidence tell us there's an opportunity to do that's different? And I think of that as a little different than CME, which is really more centered on me as a clinician to say, okay, what is the knowledge that I need to gain? I may be sitting there listening to an expert lecture. I may, participate in something, but it's about building up my knowledge base. Whereas in the PIQI space, I really think about it as us as a team really improving our care delivery, our diagnostic approach, whatever it is within our unit, within our clinic, our system, anything like that.
Beautifully said, Jeff. I think the CME is the didactic. The PIQI is the implementation and the skill, right? And while they're both important, I'm not trying to discount one or the other. They're both important, but they do need to be acknowledged as they build upon each other. You really can't have one without the other.
Yeah.
Yeah. So I think that emphasis on real world practice settings, as Jeff said, really focus on outcomes and implementation through iterative changes over time to then lead to those systemic improvements that we have.
Just to build off of what Jeff said, this is a humbling disease, right? And so it's okay to say that it's challenging and that we can do a little bit better. That's not saying you're doing bad. That's just acknowledging that this is a complex disease. These are complex patients. The medications that we use are challenging, and you can do everything completely right and still not have the outcome you were looking for. And that's okay, right? It's just taking that mindset that we can always do better, and let's just acknowledge and admit that. And that's not saying we're doing bad. That's not a personal attack. This is a humbling disease, and we're going to continue to be humbled by it, but that doesn't mean we stop looking for ways to humble it in some way.
So building off of that, let's talk about some specific PIQI that is related to VTE in practice.
Well, I'm happy to share one story. This is one that we embarked on several years ago. One of my ER colleagues actually came to me and said, "Hey, Jeff, did you know that our guidelines recommend a patient with an acute PE who's in the emergency room but really has no risk factors for decompensation? We should be discharging that person home rather than admitting them." And I said, yeah, there's actually a lot of evidence. There's some trials to support that. It's a guideline recommendation. And he said, we don't do that. We just see PE as a diagnosis and immediately admit them. And so he said, how can we sort of work to improve this? How can we make this a better experience for patients? And oh, by the way, probably better utilization of our healthcare resources, across our system. So we sort of entered into one of these QI efforts to say, okay, is this a problem where we're at? We gathered the data. Sure enough, we were discharging fewer than 2% of patients. And then we said, okay, how many could we do? Gosh, we could get up to 30, maybe even 40% if we started using some evidence-based strategies. Well, we had to understand why. We had to talk to the clinicians, the ER docs, the NPs, the PAs who were there. We talked to the social workers, the pharmacists. We talked to the patients, and we said, what are the various barriers? How do we design a system that can address those barriers? We did a lot of those sort of iterative cycles. We do something, oh, it didn't quite work. You have to adapt and change. We figured out how to get people their anticoagulant medications in a reliable way, even if it was 3 a.m. on a Sunday morning, right? Like you have to work through all of those elements. And thankfully, we're now discharging, north of 30% of our low risk patients, whereas before we weren't doing any of that. The patients love it. It's sort of decreased some of the burden in the hospital. I think it's really improved care. It took a while and it took a multidisciplinary team, but it was that QI effort that helped us sort of improve upon what we're doing. And now we're thinking about, okay, how do we take it to that next step? Can we get even more patients eligible, or other disease states where we should be doing similar things? So continuing to work on it.
From a medication perspective, there's always room to evaluate how can we optimize our drug therapy decisions, how can we optimize transitions of care, and then leveraging the multidisciplinary team to really engage all of those folks to get their viewpoints, which really help determine everything from, our medication selection, pathways, transitions of care. It takes all of us to be able to do this well, and having that framework and working together is really the only way to overcome those barriers.
Snehal, you described sort of the challenges with medication therapy, and it reminds me of a lot of work that's been done in the VA. We know that DOACs are so much easier to prescribe than warfarin. The problem is when they're easier to prescribe, they're not always followed as closely. And then sometimes we have prescribing errors. I've seen in the literature numbers of 15, 20, even 25% of DOACs having some sort of a prescribing error. And so the VA, I think, has really been out front with saying, how can we build teams? How can we give them sort of resources within the electronic health record to identify patients who maybe need more thorough monitoring, maybe a clinical pharmacist to do a double check to make sure that that prescription is okay, so that we can ensure everyone's getting an evidence-based prescription of their anticoagulant. And when we evaluated that process, we actually found it was associated with fewer thrombotic events. So fewer strokes in the AFib patients, fewer recurrence DVTs and PEs sort of overall, when they actually made anticoagulant prescribing more evidence-based or more likely to follow the rules of the package insert. So there really is a lot of great opportunity to improve care in that domain as well.
Absolutely.
So, Jeff, with your example, you mentioned the financial impact of increasing discharge rates based on best practices, and then you just cited the improvements on patient outcomes. Are there any other impacts that either of you have seen in practice when you implement these PI/QI initiatives?
Yeah, obviously the biggest ones we're always trying to do is avoiding those clinical harms, right? If you can reduce bleeding events, if you can reduce recurrent VTE or stroke or those events, that's always going to be really important. From a health system perspective, anything you can do that reduces cost or maybe reduces some of the burden and the pressures that health systems are facing, everyone is really busy in their emergency room. If you can help get patients through the ER safely and quickly, that's good. If you can reduce unnecessary admissions, that's really good too. But don't underestimate improving the clinician experience and improving the patient experience. We find that for a lot of our clinicians, when they know that they have a clinical pharmacist that they can rely on to help them pick the right anticoagulant for an individual patient or make adjustments, or even just calling a patient to help deal with, some of the things that happen, that reassurance is so valuable to a clinician, helps with burnout. And then the patients love it, right? Because they have a super knowledgeable person who's calling and helping to explain things to them. Maybe they didn't quite understand it the first time. They were in the ER, there was a lot going on. They just had their blood clot and, they may not remember everything. Now they get this nice phone call from somebody who can help walk them through their therapy, answer any questions they have. That's really great from a patient experience as well. So those are also important things to measure.
Yeah, Jeff, I was thinking that we started out talking about at the systems level, but really at that individual provider and patient level, when you think about burnout that exists, shortage of healthcare workers, and thinking about that satisfaction that comes both on the provider and patient side, and the agency of a provider to identify specific treatments and then actions for each individualized patient.
And I think when people work together, it strengthens a sense of team. And that is just invaluable, right? If you're working in any healthcare system and you feel alone, that's just the worst place to be. You're not then able to provide great care to your patients. But if you feel like I'm a part of a team, I'm a part of a really talented team where I'm a valued member and other people are valued as well, and we're all going to work together, suddenly you just feel like you can do more and you can give more to your patients, which is going to lead to better outcomes. So, I think that is such an important element to try and measure, tell those stories in any way you can.
Yeah, it absolutely reinforces those other components we talked about, the importance of team collaboration, communication, efficiency, and ultimately improving patient outcomes. Do either of you have other PIQI examples of interventions that you've seen and the impact that they've had? Jeff provided two of them so far.
Just building really quickly, it's parallel to what Jeff had to say, but I think the pharmacy side, having a standardized meds to beds program has really helped with that transition to care piece. Working together within our teams to identify the right medication for this patient at this time, and then being able to bring it to the bedside before patients are discharged, and allows additional contact and education in a multidisciplinary fashion. So not just done by pharmacists, but done by our physician colleagues and our nursing colleagues. A patient hearing something multiple times while they're still in the hospital, I think helps a little bit in terms of demystifying everything that's going on, and allows us to pretty much, connect the dots for a patient to make that as hopefully as less scary as possible. So that's been a win for us in this space, but really across our spectrum of our hospital. And Jeff, the ER piece and saving money on admission is huge, but being able to save length of stay days is another opportunity. And for our pharmacy team to be able to tap into that through a transition to care and a medication to beds program has been really helpful for us.
That's a great example, Snehal, and really impactful. As we conclude our discussion today, do either of you have any additional comments or considerations that we haven't mentioned yet today?
I don't know if it's anything additional. I would just say that there's such a vast opportunity to improve the care for patients who have venous thromboembolism. I mean, even if you just look at anticoagulation therapy, right? There's so many different stages of therapy. There's so many opportunities to think about how we improve it. But then even beyond that, there's the prevention element. There's the, interventional treatment element. There's the long-term follow-up and, consequences elements and all of that. And so I would really encourage anyone who has interest in this space, go to the guidelines, go to the evidence, figure out what we should be doing, but maybe we're not doing, and then use that as motivation to say, how can we make care better for patients? And I think if you find an area that you're passionate about, you get a couple people around you to work on it, hopefully you'll get a good success, and then that'll sort of set up an opportunity to do even more good work that at the end of the day is about improving outcomes for our patients. And that's what we're really trying to achieve.
Well said, Jeff. You're not alone. It takes a village, right? And there are resources. Find your local champions. Find the resources that are available at the local, state, national, and international level, right? There's a lot of stuff out there. It's all great, right? And so keep working at it, because change can happen with just one individual. So you're not alone. Go on and do great things.
Well, I want to thank you both for this insightful and practical discussion. Your expertise has really provided a clear roadmap for our audience on how to move beyond that knowledge acquisition phase into real-world practice transformation in VTE care. We began our segment today by exploring how the insights from our CME series can be leveraged to advance protocol-based practice and personalized treatments, but also it can be used to strengthen communication across the care continuum and address some common barriers in our daily workflow. We looked into performance and quality improvement, and as you both so effectively articulated, our traditional CME focuses on knowledge acquisition, which is important. PIQI is all about applying that learning, measuring the outcomes, and really using that to drive systemic improvements. It's a critical tool that improves our patient outcomes, as we learned from the several great examples that both of you provided. It also enhances team collaboration and ultimately ensures that the practice that we have aligns with the latest national guidelines. Finally, we discussed some tangible impacts of these efforts, from achieving measurable improvements in metrics. We gave the example of readmission rates. We can empower staff and ultimately drive resource optimization. The examples that you both provided really gave our audience some concrete next steps to begin or enhance their own QI journey. So thank you for that. This entire series was designed to be a catalyst for change, and I think that this final session we had today provides the practical framework we need to make that change a reality. On behalf of the AHA and our panelists, I want to thank you, the audience, for joining us for this final session and for your commitment to improving VTE care. Thank you again to our panelists and to the American Heart Association. This series is available through major podcast platforms. To claim credit, please visit learn.heart.org. Thank you.